Hi, everybody. Thank you very much for joining us. My name is Anubha Bhonsle, and I do Newsworthy. News that's worthy of your time, attention, and mental health. For a moment, let's all pretend that the COVID-19 vaccine is here. All problems solved. For now, till now, a lot of our attention, a lot of our anxieties, a lot of our plans have been focused on the COVID-19 vaccine, giving us the impression that this is the biggest challenge. Actually, it's not. What happens after the vaccine is a tough task as well. Some would argue much tougher. Who gets the vaccine? Obviously, a question on top of everybody's mind. But apart from that, how will it be distributed? Who will administer the vaccine? How will it get stored? What will it cost? All these are extremely crucial questions that the government is considering, and one that we need to understand and inform ourselves better. That's the focus of this conversation. Before I bring in my guest and start this conversation, I have a very, very simple ask. If you're watching this on YouTube, please subscribe to this channel and click the bell icon. It helps our work reach you. If you're watching this on Instagram or Facebook, please join us, follow us. I hate that word, follow. So please join us. It helps our work reach everybody and many more people as it should. Okay, done with the ask, back to work. Joining me today is CK Mishra. He chaired the Centre's Empowered Group on COVID-19, especially on the availability of hospitals, quarantine and isolation facilities till about May end, when he retired as the former secretary in the government of India, and someone who's best placed really to answer all our questions, nuts and bolts, as well as the big picture of what would a rollout of a COVID-19 vaccine look like if and when it comes. Mr. Mishra, thank you very much for your time.
Thank you.
With your permission, I'm going to just throw some broad statistics for our viewers to get a sense of how immense or huge this task is. India conducts one of the world's largest immunization programs for children and mothers. Our universal immunization program targets 26.7 million newborns and 29 million pregnant women. 390 million doses of vaccines are given over 9 million sessions. And India Spend, as well as the health ministry, did some number crunching to effectively indicate that to administer 400 to 500 million doses of COVID-19 vaccine by the first 2 quarters of 2021, India will perhaps have to double the total number of vaccinations given in the public sector program. So let's get this conversation started, Mr. Mishra. And I'm throwing a really broad question at you first. What would the components of a rollout of a COVID-19 vaccine look like? It will obviously have the center, the state, the public sector, and the private sector. But obviously, perhaps the center takes the lead, right?
Well, before I get into that, let me explain one thing to you that we run one of the largest universal immunization programs in the world. And you just mentioned some figures which obviously are there. And therefore, a system does exist in India to reach out to the last mile and actually vaccinate. And we have a system going, not just of vaccinators, but also of cold chain professionals, etc. Having said that, ever since we launched Mission Indradhanush in 2016, this has got intensified, and now today, globally, we account for one of the largest vaccination programs that we run. Now, to get to your last question first, everybody has a role to play. The states will have their own role. The local authorities will have their own role. But the central piece will be the government of India. So far in universal immunization, we've been piloting the vaccines from the government of India, and the vaccination program is taking place in the state governments. So that is the kind of thing we've been doing. One of the things that the rollout of the vaccine must take care of, and that's a feeling that I have very strongly, is that you cannot have a program at the cost of universal immunization. So we will have to keep running our universal immunization program, both for children and pregnant women and others. and top it up with a system which takes care of the additionality of the vaccination program for the COVID. Now, please, let's also understand that COVID is not a regular, going to be a regular feature for a very, very long time. But universal immunization is going to continue for a very long time. So we'll have to top that up and create that additionality.
You make a very important point there, and I've taken it into consideration as part of our conversation as to how we can avoid our universal immunization program to fall as a collateral, especially when we are focusing on COVID-19. But so far, as for all that we know from the government, we know the states and the union territories have been asked not to separately try and procure any vaccines on COVID-19, that the center will be directly dealing with the drug makers. Considering the fact that health is a state subject, and from what we know so far, as far as our immunization program is concerned, it's got a fairly centralized focus. How does that communication take place? Or would you suggest that since we do run one of the programs, that communication pipeline is already very, very clear and solidified?
I personally feel that we don't need to run a parallel new communication program. We have a system going, we need to build on that system, and we need to add on that system. Now, to your point about health being a state subject, it's a very relevant point. And whatever the center does or has done so far, and to the best of my knowledge, does not preclude the state from doing what it wants to do. Even in the universal immunization program, if you look at it, HPV, for example, Punjab took it up much earlier before other states. There are other vaccines which the southern states took up much before the universal immunization came in.
Yes.
So states are free to do that. The coordinating and the central piece of this entire puzzle will be the government of India. I presume that's the way it's going to work
out. Mr. Mishra, are we then, if we're not to build a parallel structure, would you say that we are going to rely on the infrastructure, that whether it exists in the forms of ASHA workers or ANMs, even in this case?
There is a slight difference which we need to understand. It's not about, currently the ANMs are the ones who are actually administering the vaccines in the field. So we'll have to find additional structures, parallel structures, which I feel that is there, and I'm sure the government of India is also working on it, and those plans are already with them. We will have to deploy additional manpower to take care of the COVID vaccination. It's an injectable. So to that extent, you need a somewhat trained manpower to go in. ASHAs have been extremely good mobilizers, but you can't treat them as vaccinators. So you have to rely on this medical system that you have down to the ANM level, where you will need to train people to do this additional job.
That leads to sort of two very basic questions. What do you believe, in your expertise, would those numbers look like? And can our system really bear the burden of this sort of additional mass vaccination? I'm calling it mass, but I know that they will go through some sort of sections of prioritizing when they are administered, but can our system really bear the burden?
See, let me prefix whatever I'm going to say by saying that since I'm not very active part of the system any longer, I am relying on whatever I've been talking to people, they have been discussing with me. Our government of India already has a plan ready. And I would say that from whatever I know, it's a robust plan that is ready. Vaccinating people has two components. It's not just about the infrastructure that you build in terms of cold chain, etc., which will need additionality. And not just manpower, it's also availability of vaccine.
Yes.
Therefore, there is both a supply side constraint which may be there, and a capacity constraint which may be there. So what do? Naturally, you prioritize. And I think India will be prioritizing And I was speaking to the health officials very recently. I think they have a plan ready already. I mean, you've been hearing, the experts will explain it better, but you've been hearing that it is the health professionals and the frontline workers and the more vulnerable population which will come first. But this is going to be a continuous flow. Coming first does not mean phase one starts and ends. It's going to be a continuous process. So one will follow the other. And as you keep getting vaccines, you keep expanding. Let me give you a parallel. Let us say we introduced the pentavalent vaccine in this country. Now, when we introduced the pentavalent vaccines, we introduced it in 4 or 5 states. But that did not mean that it got restricted to 4 or 5 states. Next year saw 10 more, and now we have the entire country. So that is the way we've been going. It is a lesson already with us. We've been doing it that way, and the only difference here is that it may not be geographical, it may be the population slices. Which part of the population gets when. One of the most critical things in this exercise, according to me, is line listing. And getting the people who... Now, line listing actually means that you identify who are there in your phase one.
Yes.
You have to get those names down. And then you have to, once you know that, then you know the geographies of those names. Once you know the geographies of their name, then you know the manpower available in that area. Then, for example, a district can plan whether it needs to shift some of its manpower from one part to another, or a state can plan that way. So it will take a lot of planning depending on the numbers that you have. Production capacity, I think the way anyway, India is one of the largest producers of vaccine in the world. And we have that capacity. How do we leverage it? How do we get it into our system? And how do we maintain the flow? Now, one of the very good things that we have going for us, and I am very proud of having worked with that system and introduced it, is the EVIN system, which is the electronic vaccine tracing. Now, if we are able to build a kind of a superstructure on top of that and fit in COVID into that, that is going to be a very good system. Now, we also have the digital health mission, which will contribute to it.
Mr. Mishra, the sense that I'm getting is that for each of these pieces, you are suggesting or advocating for no parallel structures to be made, but sort of interventions to be made within the existing pipeline.
No, I would put it slightly differently.
Okay.
What I'm trying to say is that no parallel structures in terms of externalities, but additional structures within the system.
Okay.
You will have to identify additional structures within the system. And of course, this will be a huge exercise. And my own sense is that it is not going to limit it to the public sector alone.
The private sector will have to be brought in.
Yes, they will have to be brought in.
Mr. Mishra, while preparing for this conversation, I was most intrigued, and in our coverage of public health in the past, I've been most intrigued that so much of our burden goes to the private sector. I mean, there's some figures that go on from 70 to 80% as far as the health burden is concerned. But when it comes to vaccinations, the private sector has such a small role. Why is
that? When we talk about universal immunization, let me first qualify this statement by saying that I am a strong believer that primary health, preventive and promotive health, has been and should be the government's priority.
Okay.
It will help things much more if the private sector joins in. Unfortunately, in India, we've not seen too much of a participation from the private sector in preventive promotive health programs. Universal immunization, being a free immunization program, it is largely taken up by government. And I'll give you an example of why I am saying this. You see, we are the ones, government systems under the National Health Mission is the one which maintains the register of all pregnant women in the country. So we know what the childbirth is and where it is. So that system knows where exactly to vaccinate, which place has how many children.
Sure.
Now, I'll give you one example, live example. In 2016, when we launched Mission Indradhanush, one of the objectives was to find out the missing children.
Hmm.
Children who did not get full coverage, all the 5 antigens.
Hmm.
So we were actually able to track it down to village-wise number of children who were left out.
Hmm.
This kind of a repository is not available with the private sector, or for some reason we've not been able to put the private sector into the system. So therefore, the immunization that the private sector is doing is largely outside this system, where people are going to them on a paid basis.
Yes, yes. But you are seeing a role for them as far as the COVID-19 vaccine is concerned.
Ideally, I would think there is a role, and if we do that, it will supplement government efforts.
I just want to turn back to the conversation we were having about prioritizing the administration of the vaccine. And just for the benefit of our viewers, who gets it? How do we prioritize the vaccine? Is sort of, I'm presuming, the big question in everyone's mind. It is fairly clear, and I think it's a good assumption to make that everyone cannot get it at once and in one go. Limited quantities will be available, as you said, in the first few months. And even in the best case situation, preventing our mortality or protecting our frontline workers is perhaps going to be the task for the government of the day. So fair to say that it's sort of an intuitive task, and the most vulnerable will be addressed first, Mr. Mishra. There are some figures that the government has put out about the process of identifying about 30 crore priority beneficiaries across India. These are figures that are now publicly available. My question is, supposing the states were to draw up these lists, right? How are we going to then sort of further triage this number in a staged manner? And again, I'm sort of trying to put two pieces together: the government's figure of identifying 30 crore beneficiaries, taking the state's help, but then let's say Mr. Poonawalla coming up with a figure that even if the front runner was to sort of get a green signal on all counts, he will be able to have only about 10 crore doses ready in the first go. So how do you actually triage a list like that, which is already made up of people who need it urgently?
Let me begin by saying that I may not be best suited to get into numbers and the methodology, because there are experts working on it. But I've also been reading, as you have been, and I have a sense of how it could proceed. See, if X manufacturer says that it is 10 crores, please remember that I don't think a decision has been taken that we'll have only one kind of a vaccine going, or 2 vaccines going, or 3 vaccines going. So the numbers will depend on that. How many vaccines do we accept? Second, even the 30 crore that you are talking about, which have publicly come out, it's not a one-day affair.
Yes.
It's going to be a long-drawn affair. So that gives you the timeline for the production to keep trickling in. It's not just about a one-time production coming in. The supplies will be sent to the states, and I strongly feel that the center should take care of the supplies, the state should take care of the nitty-gritties of actually reaching it out to field and actually vaccinating. I am not very sure if this is the line of thinking right now, but what I am told is that these basic primary jobs the government has already done. Yeah. They're ready with the blueprint, and I mean, it's commendable that they are ready much before time, so that when the vaccine actually comes, nobody will be caught napping. We'll actually be able to roll out very fast.
You've touched on this in terms of our cold storage facilities, in terms of the vials that will be needed for the vaccine and stuff. And I want to focus on that and the infrastructure bit a little bit, because obviously everyone knows a vaccine is not just a vaccine. It needs a whole host of facilities, storage, temperature, etc. Again, throwing some figures for perspective, the UIP has over 27,000 cold chain points, 76,000 items of cold chain equipment. Majority of them are located in our primary health centers, our CHCs, and our sub-centers, and there is a number of 55,000 staff that run that cold chain. A lot of this is thanks to our ongoing immunization programs, although there's some capacity courtesy our polio program. Simple question, is this existing cold chain going to be enough?
My own take is that we will need to supplement. Now, the whole debate hinges around the fact that how much space can you squeeze out from your universal immunization program
without it impacting your immunity.
So if that space is large enough, perhaps we'll be able to accommodate. And I also feel that this additionality will depend on geography. Some states may actually have enough space to do that. Some states may not. So it will have to be a state-specific exercise to find out. And I just read in the newspapers today that the health secretary was very right when he said yesterday that each state will have to draw up its plan, and then we will get to know where we stand. So I mean, to answer your question, perhaps we'll need additionalities.
One question, Mr.
To
Mishra.
further answer your question, I don't think that's a very difficult one either.
It's not a difficult one.
We've ramped up our cold chain in very little time in the past. We have the technology now, and I think it's eminently doable. You see, you are talking about a population of about 30 crores or 35 crores, whatever the number is, spread over the entire country. So 28,000 cold chain points or the state level major storage that we have. I mean, this is all available with us to start with. As you go along and the numbers keep increasing, you can increase that.
I'm only pushing this point a little further because some of the other people that I spoke to who have pointed out some bits of concerns are indicating 2 points. One, that most vaccines provided under government programs are stored at a particular temperature in the cold chain, right? 2 to 8 degrees. And I'm just saying that to me, it felt like nitty-gritty as well, but then I realized how important it was. AstraZeneca / Oxford, Johnson & Johnson, and Novavax are possibly going to be stored at the same temperature. That's what, again, out in the public domain, so that looks fine. But if there was another candidate that we have brought in that has succeeded and has been included, and it needs us to have be stored at a different temperature, recalibrating our cold chains, these seem like small issues, but I'm wondering whether we are prepared for it, whether this affects the efficacy of the vaccine, and so on and so forth.
Anubha, 2 things. A, you must understand that the entire exercise is still work in progress. And B, we have never, and this has been the global experience and the entire globe acknowledges it, compromised or have let the efficacy of the vaccine suffer. So that training is there. And I'm sure the expert committee which is looking at it, and I know that the expert committee which is looking at it has actually been looking at these points. There will be temperature differences. There'll be some places where you'll need to actually create a parallel system. There'll be some places where the temperature will be manageable and you will be able to store them there. It also depends on what kind of a movement plan and how long a storage are you planning.
From it coming to
if you reefer vans moving, how much of a storage plan are you planning? How much of a quick movement are you planning? How much of a movement versus the disposal in a day are you planning? These are numbers which will have to be planned, and the expert committee is spending a lot of time discussing this because they're aware of all these issues. It's not that they're not aware of all these issues. So, and I am sure all these issues will get addressed.
One of the concerns which if I can just push while you're saying this, is it also originates, and you've got good experience in it, it also originates from that last minute rush, so to speak, that we saw between government and private sector when it came to manufacturing items like the PPEs. Then you imported them, then you got them, then you found they were faulty, etc. And I think that experience is also leading some people to have concerns about this.
See, everything you do is a learning. And let me tell you, one of the biggest learnings
Mm,
is from day one in Corona has been that you have learned every week. Something new has happened every week, and we've been coping. It's about coping.
mm,
There is a difference between what you say in terms of PPEs or N95s and the vaccine rollout. And according to me, the critical difference, Anubha, is that in the PPE and N95 scenario,
mm,
you had zero experience, no manufacturing. And yet, you overcame today to be a country which can actually export. In the vaccine scenario, you have an experience, you have an infrastructure which may not be adequate but exists.
mm,
So, adaptability, according to me, if we were able to adapt to a critical thing like, N95
mm.
or PPE, I think it will be slightly more easier to adapt to a rollout of vaccine where we're used to it.
I'm going to try and stitch this conversation towards its end and sort of chalk out the learnings with you. But I want to bring in one aspect that you touched upon early in the conversation about collaterals and our overall immunization program not suffering on account of COVID-19 vaccine. Do you really believe that would happen? Also, because the numbers that came out during the lockdown period, even after we sort of unlocked down, have indicated that we have suffered on some of those indicators.
Yes, there has been some disruption,
Mm.
and it's not just because the vaccines were not available or the ANMs were not available. It was also because the whole thing was in such a situation that
Yes.
the children were not moving, the movements were restricted. So that was an extraordinary situation where this thing happened.
Mm.
I hope and sincerely hope that we are able to make up for that lost time and actually get back to full vaccination, because one of the biggest key to making children survive and making sure that our MMR and IMR remains on that improvement track throughout, according to me, is good vaccination.
Mm. But
And
what
when
makes
we
you
introduce
so hopeful that these will not suffer as collaterals once the COVID-19 vaccination plan starts?
I think the entire health sector,
Mm.
Government of India and states included, are very conscious of the fact
Mm.
that the long-term damage to a collateral suffering of universal immunization will be very high.
Mm.
So I hope and very strongly believe that that will not happen. We will be able to actually get on with our routine immunization and supplement it with this vaccine.
I want to ask you sort of a hot potato question, and I know that no free national COVID-19 immunization program has been announced, except possibly a sort of offhand defense that it's going to be free for everyone and everyone will get it, as the Prime Minister said. But just in your experience in the health sector, will it be free? Should it be free? Should it be free for some?
Uh, I am not in the best position to answer that, but I'll just give you something else. You are continuously moving in the direction of universal immunization, universal health.
Mm.
So if that is the direction you take, then it should be universally available to any and everybody who wants. But it is a call that the government has to take. And I mean, you just mentioned the Prime Minister's already stated that you can't say anything beyond that.
Mm.
But these things are something that would need to come out. My only feeling is that we need to keep it simple. The
Okay.
process must be very simple for it to reach down. We need not create parallel lines and complications in doing this. If we can do that, I think we'll be successful.
Could
And
you
we have the
explain that
experience
further,
and
sir?
involved.
Could you explain
Sorry?
that further as to what it means when you say that the process should be?
See, if you start creating groups within groups,
Hmm.
the free, non-free, etc., etc.,
Hmm.
there are complications which add to the system.
Hmm.
So you have a system which is stressed. We are able to use it. The simpler the solution and the simpler the rollout plan, the better the implementation results will be, is what I'm trying to say.
One final question and we'll wrap up this conversation then. We have learnings from the fact that we have the world's largest immunization program. We have learnings from our polio vaccination program. You've articulated some great strengths in the system. Uh, as sort of a public health expert, what would you say to sort of citizens, who are invested in finding out about the COVID-19 vaccine and its progress each and every day? It's sort of like a tracking people do, or are sort of making their life decisions based on it. What do you believe we should take the maximum sort of strength from?
We need to take strength from the fact that we have a resilient system which will reach people. And I think at the end of the day, it will be patience which will be very, very critical. We are a very large country. Please remember that. And government is working very hard, but there are certain things which do not come to you because there are other physical limitations which you just cannot surmount. So believe in the hard work being put in by government and have a little patience, which is perhaps it will work.
Patience is the call of the day. Mr. Mishra, that's a great note to end this conversation on. I'm extremely thankful for answering all the basic questions, the nuts and bolts, and giving us a good, healthy perspective of what the next couple of months would look like. I truly appreciate it.
Thank you, Anubha. Thank you. It was a pleasure talking to you. Thank you very much.
Thank you very much, Mr. Mishra.